Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you are using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please make sure your microphone is muted for the duration of the call, unless you are speaking or asking questions. Questions can be submitted at any time during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows toward the end of the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman-Bridges and Susan King-Lanier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and select the view that works best for you. Today's agenda includes introductions and then updates regarding the webinar schedule, Appendix K, behavioral health rate increases, and LME MCO consolidation. Our topic for today is the crisis system, and we will discuss 988, new funding for North Carolina's crisis system, mobile crisis, facility-based crisis centers, behavioral health urgent care, mobile response stabilization services, NC START, BH scan, and non-law enforcement transportation. There will also be time for questions. At this time, I would like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Dina. Hello, everyone. It is great to be here with you today in our side-by-side webinar. So I am Kelly Crosby. It's great to meet you all or to see you again if you've been with us before or we've met in other venues. Super glad to be here. That's just a little bit about me. For others, I'd like to do a quick description. I've got glasses on, I've got a black dress and a blue sweater, and I've got my hair pulled back. And I am sitting in a room with a strange fluorescent overhead light. So I am also a licensed clinical social worker and a mom, and I am a person with lived experience. So I've worked in the mental health and substance use and IDD and TBI field for a very, very long time. And I am an advocate, and my work is personal, and I believe our work should be incredibly collaborative because we're all in this system together. All right, we have a lot to cover today, so I'm going to go quickly through announcements. And I'm going to go quickly save the bulk of time for our crisis topic. And we'd love to leave about 15 minutes for questions. So we've got SMEs here, subject matter experts today, to answer questions live in the chat, but also to answer questions verbally at the end. So that's our goal. Let's real quick look at the schedule for upcoming webinars because we've got some holiday season upon us. Today, we're talking about the crisis system. And remember, specifically, we got legislative investments in the crisis system. So we're going to talk a bit about how we see our crisis system right now and begin to introduce the notion of where we might fund. We're going to break that down in other work groups. I'll tell you about that in a minute. December 4th, we're going to go on to another budget line item, which are services and supports we have for individuals involved in the justice system. That's youth, that's adults. These are folks involved in the justice system with mental health, IDD, TBI, SUD, all the letters. Sorry about that. And then in early January, we're going to talk about workforce. So that's mental health and substance use workforce and direct support professionals for folks with intellectual and developmental disabilities and traumatic brain injury, as well as peer supports. You know, I love peer supports. I think peer supports are marvelous for our system. So we'll be talking about that peer supports is an integral part of our workforce as well. So again, breaking down our investments, our legislative investments, because we want to share with you our thinking and our strategy. Next slide. Remember, this is our community collaborative system. Side by Side is the meeting every month where we, big picture to a large audience, talk about what we're working on in the system. It could be our strategic plan. It could be our legislative funding. We're going to always do hot topic announcements. You'll see some of those. That's sort of the big place we meet. We also have 4 specific groups that we meet with every month. So we cascade the side-by-side topic down into our CFAC. So if you're a consumer or family member and you'd love to be involved, we'd love you to be involved. Come here and get involved in your local Consumer and Family Advisory Council or the state CFAC. Those are open meetings. There's a committee they meet, but it is an open meeting with open time for folks to contribute and ask questions. We also meet with the clinical leadership of our LME MCOs every week on these very topics, every month, excuse me. We meet with our providers and our provider associations. Our monthly meeting is tomorrow. And we also have a wonderful working group with the North Carolina Healthcare Association, the behavioral health folks in particular. So those are our routine meetings where we break down these side-by-side topics a little bit more. We call this webinar side-by-side because, again, we envision doing things with you side-by-side in our system, collaboratively and together. Now, that's our routine structure of meetings. But because we got these new budget investments, we needed to stand up some advisory groups because we want to make sure we are assessing the system, getting lots of feedback, spending the money as wisely as we can to kind of system improvements and see the kind of outcomes we want. So the 4 work groups we've established is a workforce work group on peers, a workforce work group on direct support professionals, an advisory group on the crisis system. We had our first advisory meeting this morning, and we have an advisory meeting on supports for individuals involved in the justice system. Now, in that CFAC meeting, in the LME meeting, in the provider meeting, in the hospital meeting, we have gotten volunteers for those work groups, but feel free. There'll be ways to contact us after this. You can even put it in the chat if you're like, hey, I'd like to be at one of those routine meetings you have, or I'd like to be in one of those advisory committees. Please raise your hand and you are very welcome. All right, next slide. How do you join? Remember I said if you're a consumer and family, we want you. How do you join your local CFAC? These slides will be posted, but remember, every LME MCO has a local consumer and family advisory committee, and this is how you connect to be part of that. We also have the state consumer and family advisory committee, and that meets every month as well. So we will send this slide deck out. It will be posted, excuse me, and so you will see all of these contacts. Next slide. So let's do updates first before we get into our crisis continuum and some data. Medicaid published a bulletin that talked about Appendix K flexibilities. That's a lot of jargon, but Appendix K, we have the innovations waiver and the traumatic brain injury waiver. Appendix K were flexibilities that the state got to help us get through the COVID public health emergency. That just allowed, quite frankly, just flexibilities in how services were delivered, the way they could be delivered, the person that could deliver them, like a family member. Medicaid has made changes like every state in the nation has, as the federal government has rolled back all the COVID extra money. States have had to submit waiver amendments to change all those flexibilities. Medicaid in North Carolina has their submission in, but it's not approved yet by the federal government. And so the federal government has extended those flexibilities until the end of February of next year. So that's exciting. So there's some more time to have those flexibilities for innovations waiver and the traumatic brain injury waiver. Now, at some point, CMS is going to approve that waiver. And when they do, or the changes in Appendix K, when they do, Medicaid will publish that. And we, in partnership with them, will make sure that we have some listening sessions and work closely with them and the LME MCOs to help people understand those changes and to get ready for those changes. There are some hot links in this PowerPoint, so you can see the places where Medicaid has published everything from an explanation of all the changes, an explanation of the new waiver, and an explanation of the timeline. So you'll see those hot links here in the slides. All right, next slide. This is so exciting. Remember how we got rate increases for the things we're talking about today, crisis and justice and everything else. We also got reoccurring funds from the General Assembly to increase rates for behavioral health services. Now, the rates aren't standard across the board for every service. We have lots of services, right? We have outpatient services by psychiatrists and psychologists and licensed clinical social workers. We've got MST and intensive in-home. We've got PRTF and residential services. We've got lots of services, right? They got different rate increases, but overall the rate increases are about 20%. That's extraordinary. Rate increases should help us get more individuals interested in coming to the behavioral health system. We're going to pay licensed professionals more, psychiatrists more, psychologists more. We're going to have better inpatient hospital rates, which is very exciting. So hopefully we'll be able to have more beds available for people that need inpatient care. We were able to raise rates on alternatives to hospitalization. We'll show you some of those today. So our community-based crisis services and our crisis receiving centers, you'll see that. And we're able to invest in community-based services again. So we have more community-based services like intensive in-home or ACT or community support team. So folks are able to get those services and avoid higher cost levels of care. Now, the rate increases are going to be effective after January 1st. So you have about a 6-week time. The LME MCOs are getting this additional money, and they will publish updated rate schedules. So essentially, in many cases, but not all, Medicaid is setting a rate floor. And so the LMEs will set rates based on that. But there's a Medicaid bulletin. Please see the hot link that describes this more in detail. It's a very dense bulletin, has lots of information, but you want to read that. The last thing I'll hit on really quickly, and I think everybody knows this already, the secretary, before he made consolidation decisions, he put out some values and a framework for thinking about consolidating the LMEs. And he said, as I listened to the community, he met with the community, he met with our CFAC, he met with providers, he met with the LME MCOs. He wanted to get that kind of feedback. And he said, here are my 3 principles. Consolidation should be about what is best for the people we serve and for providers in those systems. How can we use consolidation to move us to tailored plans more quickly? We've, pushed tailored plans down the road a few times already, and that's a lot. It's hard to wait and be in that level of uncertainty. And how can we consolidate to have less complexity in the system and the least amount of disruption that we can? So the secretary sent out a directive in early November. Everyone should have seen it. It's very public. That Sandhills Center will be dissolved and East Point will consolidate with Sandhills as they had requested. And that there are 3 counties that do go to other LME MCOs, and that East Point, that surviving entity of Sandhills and East Points, will further consolidate with Trillium. So we will be publishing more information on that. I will say all of the consolidation work that the LMEs will do, that we will do in support of them, will follow those 3 values. So we'll be publishing some information with Medicaid very soon that will talk about how consumers can expect to continue to receive services, what will happen with your Medicaid card. If you're a provider and you have a contract, what will happen? We've gotten wonderful feedback from the community, not only on consolidation, but the things we should pay attention to make sure consolidation works well. So we're going to be publishing a question and answer document with some guidelines for how we expect consolidation to work. We will do our best to keep folks informed and in the loop. It's a big shift and a big change. And so we will do our very best to be transparent and communicate as much as we can. All right, next slide. So these are just some things that we asked the community, the secretary asked the community, and you are welcome to, at the end of this session in the Q&A time, to tell us your thoughts and questions about consolidation. We welcome them now. We welcome you sending us questions in the chat or after this webinar, because it helps us build a better FAQ document and build a better process. Okay, next slide. So let's dive into today's session. So North Carolina, here's what we hear about North Carolina's crisis system. So what I'm going to do today is to tell you some of the information we've heard about our crisis system. We're going to talk about the financial investments the General Assembly gave us for the crisis system. And then we're going to talk about the component parts. We actually have services in the crisis system now. We're going to show you data on how we're using those services or not, because we want folks to get a picture of the crisis system, what it looks like now and what we're aiming for. But one of the first things we want to level set on is, what do folks think about our current crisis system? And we talk to lots of people. I don't just talk to consumers and families in the system. I don't just talk to LMEs or providers. I talk to hospitals, of course, right? You saw our advisory groups, but also talk to just lots of people. I meet high school students and I talk to DSS directors, and I get to meet lots of people who maybe aren't as familiar with the system. So here's some of the things I hear all the time. What is 988? And there might be some of you on the call saying, what is 988? I don't know what it is. And for people that have heard of it, they say, can I trust it? I know what to expect when I call 911. Can I trust what happens when I call 988? When I talk about mobile crisis, which we'll talk about later, I get people saying, what is that? I've never heard of mobile crisis before. And maybe some of you on this call right now are like, I don't know what mobile crisis is either. I've heard people say, sure, I know what mobile crisis is, and it's a great idea, but I can't wait 5 hours for a crisis response, right? And that's not the fault of mobile crisis providers, right? We have access issues, right? Okay, so mobile crisis providers are great. We also know, and I'll show you data in a minute, we have way too many people waiting in emergency departments, right? So people are calling 911, going by ambulance or even police vehicle to emergency departments, where over 350 people are waiting every day. Was there a way to provide alternative crisis response and stabilize them in the community? I don't know. We also hear, I'm glad you have emergency responses, but I don't trust that they can meet my needs, right? My child has autism. I don't think that if I call a mobile crisis team, they will be able to meet the needs of my child. So I feel safer calling 911 because the paramedic will come and they'll know what to do, right? So I hear comments like that, like, I do know about the system, but it's not able to meet my needs. Or if my loved one has a substance use issue, I'm calling an ambulance. I'm not calling 988, or I'm not calling mobile crisis. So I hear that a lot. It's not enough to meet my needs, right? I also hear, dang, that sounds good. You have a crisis center people can go to. I love it. How can I get one of those in my area? So I hear that a lot too. Sounds good. How do I get one? All right. So next slide. This is the system we need to have. And I love this slide, y'all, but it's not because our awesome, wonderful team came up with it. This is a national concept. So this is what our crisis continuum should look like. We should have someone to talk to. That's what 988 is. Somebody to talk to, and I'll show you 988 statistics soon. We are also launching in about 75 days our peer warm line, which we're so excited about, another 24/7 peer-led resource for the state, so stay tuned. So besides having someone to talk to, we need someone to respond. So we need mobile crisis teams. We also need well-trained law enforcement or EMS or partnership, if that's the right response, right? Sometimes that is absolutely the right response. Then we need a safe place to go. So we need more behavioral health urgent cares. We need more facility-based crisis. We need more peer and community respite. We need more NC START. And then we'll talk about all those things today. So these are the component parts of the system. That system's critical. That system is a trauma-informed system, is specialized for people in mental health or substance use crisis, right? And that is inclusive of people with IDD and traumatic brain injury, right? Everybody, we all have crises. And sometimes we have to be really mindful about when we're having a mental health crisis, that we have the least traumatic and the most therapeutic response to it, right? And that's not always an ambulance, and it's not always a policeman, or it's not always a fire truck. And sometimes it needs to be quieter, and it needs to be informed, like mental health and crisis informed. And that's not, we've all used 911. I've used 911. I'm eternally grateful for 911. But when we're thinking about meeting the mental health needs, when folks are having a mental health crisis, they're spiraling, they feel hopeless, they feel alone, they feel like they can't calm down, they're agitated. You got your 19-year-old child who can't calm down. You want to be able to call a mental health trusted resource to come to your home and help de-escalate the situation, maintain your level in the community, and get them the services they need. So that's the kind of crisis system we're looking for. All right, let's talk about the top. Let's talk about 988 for a second. If you don't know about 988, 988 is the national crisis line, just like 911 is national, but we all have local state operators. Our local state operators in Wilmington. So we manage 988 here, okay? It's 24/7 access to trained counselors. It is call, chat, and text, okay? When you call, you'll get a prompt. It'll say hit 2 if you want the Spanish line, hit 1 if you want the veterans line, hit 3 if you want the Trevor line. That's our LGBTQ+ line for adolescents and young adults 13 to 24, okay? We also have video phone callers that are directly routed to ASL call centers, okay? So we're trying to make it as inclusive as we can, and we're always trying to make it better. So you'll call 988, they will do a crisis assessment, They will meet your needs and they will refer you. They will deploy a mobile crisis team if necessary, or law enforcement if that is the appropriate response, like they'll do a 911 transfer. So let me tell you a little bit about the data about our 988 line right now on the next slide. So every person I mentioned is offered support. About 7,500 people every month are calling 988, call, chat, and text. That's a lot, y'all. It grows every single month. So we're getting the word out, which is good. 60% of callers are new, 40% have called before. Part of the reason that we're launching the peer line. We just think it's the right thing to do, but people are calling because they want help. They need someone to talk to and they feel better after talking to someone. 75% of the people that did call with thoughts of suicide reported feeling better after they call, which is good, right? We want that to keep going up. We want it to be effective. And we're pretty fast at answering phone lines here in North Carolina, which is good. The national average is 41 seconds. We're 14. So kudos to our call center vendor. And that's right, because when you're calling in crisis and you want help, you need someone to answer right away. If you've got to wait more than 3 rings, a lot of people hang up, right? So that's an important statistic for us. So I'm super excited to share the next slide with you today. This is our new 988 dashboard. It is on our website now. I'm sure someone will put it in the chat, the link. Oh, the dashboard, there's a hot link here in the presentation, which is really exciting. This is our rolling 12-month dashboard, and it tells you about our call volume. So since we started in July of 2022, almost 95,000 people have called. Look at that tracker across the top. Our call rate response is 98% of the time we're answering those calls, because sometimes people do hang up before we answer. Our time to answer is 14 seconds. I already told you about 40% of people are repeat callers. Now look at this statistic, it's very interesting. Over the past year, only about 11.5% of the callers were calling in crisis. In the majority of times, if you look at the reason for contacting, so that middle graph right there, people are calling for interpersonal or family reasons. Not surprisingly, people are calling because they're depressed and anxious, right? Those are the next 2 things. We have statistics that's not in here that say the percentage of people that are not even calling for themselves, they're calling for a loved one. On the next side, you see the types of support that are offered to people. So again, a lot of times people are calling, they're not necessarily in crisis, they just are trying to figure out the system and they're trying to figure out where to go. So a lot of times when they accept a resource, we're able to give them a resource that isn't necessarily mobile crisis, but it's helping them navigate the system and know where to go. Again, number 1 referral we're making is to mobile crisis, but we're making lots of referrals to other community-based services. If you look on the left-hand side, that shows the state map. So the darker the county is, it is more people per 10,000 who are calling, right? So we have certain pockets of the state where more people are calling 988. If you look in the middle section, those are our demographics. Those are the age of folks who are call, chat, and texting. Our texting and chatting tends to be younger folks, but there are some groups that we are not getting enough penetration in, especially some of our older adults that unfortunately have some higher rates of suicide. So we track that. We also track additional data, right? So we track demographic data, we know like gender data, we know race and ethnicity data. And so we look forward to, it's on our website now, and we'll be sending this out, or it'll be posted every month, because we want people to understand what we're seeing. And we have goals for ways to improve this, to improve our reach with certain communities, to make sure that people are satisfied, and also to make sure that we're able to make those community connections when people are calling. So that's our new dashboard. We're super excited about it. But again, that's the start. Someone to call. 988 is someone to call. We have a lot of folks calling. Okay, next slide. So that's someone to call. We have it already. Can be improved though. Let's talk about our new funding. So we've already broken down our new funding in one of our previous sessions, but we're always going to show you the slide and we're going to remind you, right? We're going to use this slide to walk through every month our funding. This is the first 4 lines are our crisis funding. And that is what we're explaining to you today. In our advisory groups, we're going to break down this funding and get advice. That's what an advisory group is for, on how we should spend it and where we should spend it. So we got money for crisis infrastructure, more mobile crisis, more facility-based crisis, more BHECs. We got dedicated dollars for short-term crisis stabilization, meaning We can hold beds, if you will, for kids in crisis. I'd much rather put them in a crisis stabilization facility specifically set up for mental health than having them have to wait in an emergency department. Not that I don't love emergency departments and they're wonderful and they add value, but can we get a child in a smaller mental health crisis-based setting, which might be a little better and trauma informed for them? We also got $20 million for a non-law enforcement transportation pilot. We'll talk about that in a bit. And we got money for behavioral health scan. If you don't know what that is, I'll unpack for you what behavioral health scan is. All told, this is $131 million. So please know that we're thinking about, wait, maybe it might be on my next slide. I don't want to get ahead of myself. So can you go to my next slide? Yes, here's how we're thinking about the money, right? We're already in fiscal year 24 and we don't even have the money yet. We'll get it very soon, y'all. But we're half a year over. So we're trying to be really smart. How do we spend very strategically and smartly much needed infrastructure? When you see the maps we're about to show you, you'll see, whoa, we just don't have some facility-based crisis in some places. We don't have urgent cares in some places. So there'll be some obvious places where like, yeah, we need some infrastructure to have some more of these receiving facilities or teams that we don't have right now. We're going to use data. We're going to use those advisory boards and your input to make sure that we are strategically putting these places where they need to be. We've already just had this much input from LME MCOs, and it's been vital, and from communities, because they know where they've tried to have a facility or where they need one and what the funding obstacles are. So it's just, there's a lot of better understanding community dynamics and funding so we can make sure that we're putting things in the right place. So that's year one. We've got some money to spend right away. But in year two, this is where we need to talk about innovation. So we have existing programs and we can stand up programs, but how do we need to enhance and make those things better? How do we make sure that our facility-based crisis, our crisis receiving facilities, we have them now. How do we make sure they're providing the best and innovative care, that they're staffed right, that they're well lit, they're in good, safe communities, that people know where they are, that people know how to go to them? How do we make sure that our mobile crisis teams are funded in a way that they're available, really available 24/7, and they can get there in 30 minutes? That they could even do transportation if they wanted to, that a peer was always on the team. So what are some innovations and enhancements that we can do to improve the quality of the system? So this is where we're talking about, sure, we've built more of the same old. How do we drive quality and also trust in the system? So could we have a system, but it's a system people know they can use? Okay, next slide. Let's talk about big data, right? We have too many people waiting in emergency departments every day. This is a map. This shows you every county, and this is the number of people per county waiting in emergency departments. Okay, there you go. So some issues stand out, or issues that we know when we put this together with other data. You'll see that we don't think we have enough crisis receiving facilities. That's the term for things like facility-based crisis for kids and adult, or behavioral health urgent cares. We don't think we have enough, right? So people are ending up calling 911 and going to the emergency department. And people do need to go to the emergency department, but lots of people could avoid it and instead go in the mental health crisis system. So mobile crisis services aren't necessarily meeting the needs of the community. Please don't hear me knock on mobile crisis. You guys are my heroes. I need you to hear that. Not an easy job, wonderful service. But are we funding mobile crisis teams in ways they could have a full complement of services? They could get to a community in a timely fashion? Probably not, right? So they're there and they're wonderful in concept, but have they been funded or supported enough to be as responsive as they need to be? I've already mentioned that communities don't necessarily know or trust this behavioral health system, right? Like, I've had people say to me, so like there's a crisis 911 system and then you have your own? Yeah, I mean, people ask that, and I think it's a fair and legitimate question. But I think when you talk about building a responsive, kind of a mental health crisis stabilization system that is trauma informed, because lots of people don't have medical emergencies and don't need to go to the emergency department, people start to get it. So, but we need to make sure they're effective and that people trust them and know them. And to me, a test is, I said this in a group earlier today, would you send your own family there? That's to me, I can think of nothing higher. Would I call one for my mom? Would I call one for my son? But for people waiting in emergency departments, it's not just the crisis delivery system. It really is, do we have enough good, high quality upstream services helping people get the care they need in communities so they don't end up in crisis? Or do we have lots of people that could be discharged from the emergency department, but we don't have the community level of care to discharge them to, right? So there's other factors here. And I think we're looking at all the funding to say, how do we make sure we have the right services in place? And those rates, those behavioral health rates, are part of the solution. Making sure that we're pulling in a robust workforce who are willing to provide services to help people avoid crisis. All right. So someone to call, which is 988. Remember our crisis continuum. Someone to respond. Those are our mobile crisis teams. If you don't know what a mobile crisis team is, right? These are crisis teams that respond 24/7, 365 days a year. Usually a qualified professional is the respondent. They have clinical backup, so a psychiatrist or a licensed, like a social worker, if they need to call them. Typically, they try to go to someone's home in an unmarked car, so it's not flashy. They're trained in de-escalation, and they know services in the community. So their goal is to help the person. Am I unmuted now? I seem to have been muted for a second. So their role is to go in an unmarked car, de-escalate the crisis, and link people to services in the community. The goal is to stay in the community, right? Mobile crisis team responses can exceed 2 hours sometimes. That's not a 911 response, right? And think about, you're in crisis and a family's in crisis. And we hear a lot of times they've decided to call 911 in the interim because they just can't wait, right? Again, not a fault of the mobile crisis teams, right? And we know that the level of service provided by the mobile crisis team can vary where you are in the state. And that's not really a statewide crisis system. And that's what we need to build. Some teams do transport, but not all do, which again is where we get law enforcement, we get involuntary commitment to transport. So that creates a lot of issues for the system. Okay, so really simple goals. We need enough crisis teams. We need them to be high quality, well trained. We need shorter response times. We need the community to trust them. We certainly need enough of them. That's part of the response time. Okay, next slide is going to show you mobile crisis team utilization. Look how different this is. This is crisis utilization across the state. And this is the number of people using mobile crisis by 10,000 people, just makes for more manageable numbers. Darker counties are counties using more mobile crisis. Look at that. Do you see the difference there in mobile crisis utilization across the state? Okay. We don't know why. We're not making any reasons why, right? There's a lot of reasons you could assume from this, but we want to do further research to understand how mobile crisis looks, feels differently, why we have different types of utilization across the state. All right, next slide. So that's someone to respond, right? Someone to call 988, someone to respond mobile crisis, somewhere to go. But I like saying a safe place to go. It's not just somewhere to go. It is a clean, well-lighted place. It is a safe place to go where you take your loved one. Okay, what's facility-based crisis? Again, I get that question all the time. What? People are like, what is that? So a facility-based crisis, it's a very small setting crisis stabilization facility, which makes them expensive, right? We have them for adults and for kids. Sometimes we have a wing for adults and a wing for kids. It's really short-term. It's evaluation. You got a nurse, you got a doctor on call, you got a social worker or other licensed clinician, you got qualified professionals, substance use specialists. People can stay up to 14 days. It really is like a little mini inpatient. Again, small therapeutic environment, community-based, good stuff, expensive, okay? They're not all across the state. There's not enough beds. And interestingly, we do have a couple facility-based crises that are underutilized. So that's worth looking at too. Why are they underutilized, okay? People with in a crisis may not know it's an option. There are issues with the way communities use facility-based crisis, the way that we do receiving and handoff from 911 and EMS, and so there's not a lot of consistency sometimes in the state. So, and they don't provide medical stabilization. So we know that not only do we need more facility-based crisis, we probably need some standardization and operating procedures, and maybe to fix some bugs around using facility-based crisis, because these are wonderful alternatives. So let's look at data for a second. So these are the adult licensed beds. We have 304 beds. So, okay, we have a lot more psychiatric inpatient beds, not enough, mind you. But we probably need more beds than this, but this is where they are right now. So this demonstrates that potentially some areas of the state may not have enough capacity. And again, we've learned there are counties that used to have sites on here and they just weren't able to make it a go for certain reasons. So again, we need to be thoughtful about where we develop and build new facility-based crisis. But again, if you look back at that map, don't move the slides, but if you look back at that map about where people are going to emergency departments and languishing every day, we need more of these crisis receiving facilities. Now look at the next slide for kids, y'all. Look at this. Whoa, 60? youth facility-based crisis beds across the state. Some areas of the state may not have enough capacity. I think I'm gonna go on a limb and say some areas of the state do not have enough capacity, right? Again, how do we make these trusted places in the community? How do we support building more? Because they're not cheap. And again, facility-based crisis is one of those levels of care that not everybody covers, right? So people with insurance may end up at a facility-based crisis, and we've got to use state or other dollars to pay for that care. So it can be a pretty expensive level of care, but very worth it. Next slide. Behavioral health urgent care. So somewhere to go is not just a facility-based crisis, right? So that's a longer term stay. You might be there 14 days. Behavioral health urgent cares. I'm going to show you data in a bit. So these are places where people can go. They can get triage services. They can get a risk assessment. They can get stable. You might have heard people refer to them as chairs. They're comfy chairs. Not really, but that's how people talk about them, right? They're in urgent care. You know what urgent care is. We all have urgent cares in our neighborhoods, right? Medical urgent cares. These are behavioral health urgent cares, same notion. Some are only open 12 hours a day, but some are open 24 hours a day, which is really nice. And they've got the full complement on the ready of licensed professionals, qualified professionals, peer support specialists to help people, right? They're just not available throughout the state. Again, they're pretty expensive to run. And a lot of people may not know there are options. We had a wonderful woman at the state CFAC 2 weeks ago who was saying her community finally got a BHAC. And she said, we've been working to get a BHAC for years. And she was so excited because it was an alternative place for her loved ones and friends in crisis to go to rather than having to go to an emergency department. So they're very exciting. Now let's look at data. There aren't many BHACs, y'all, very few. The blue dots are places that have 12-hour chairs, if you will. They're open 12 hours a day. And the orange are open 24. So it's not a lot, right? Only in 10 counties, we have about 90 observation chairs, okay? So we think we need more and they need to be well advertised. All right, next slide. Mobile crisis MORS. So we're back to someone to respond. So remember I talked about mobile crisis, right? What it is. Mobile crisis MORS is a little different. It's quite special. Mobile crisis MORS is for children and adolescents. So it is a dedicated crisis response. It looks like mobile crisis, right? You don't call 911, you call 988, they can send mobile crisis MORS to your home. They're specially trained to help de-escalate crisis for kids and adolescents, but they get to follow along with the family. So the idea is, how do we spend the next 2 to 4 weeks making sure the child and the family learn techniques to manage crisis, to find out what started the crisis, see if it can be avoided, and to really engage with community-based treatment. Again, the idea is, how do we keep, especially children and adolescents, from having to go to the emergency department, right? How do we keep them in community? Mobile crisis MORS is an evidence-based model. Look at the next slide. We barely have any of it, right? I think we fund about 6 teams, right? 7 counties. So we fund through block grant dollars. We fund about 7 counties right now. Alliance is about to fund 2 more. So we don't have a lot of counties where we're covering this, but we are serving about 70 people right now. And states that are using this, I mean, we've just started it, y'all, but states that are using this, they're already seeing market reductions among with children going to emergency departments. And we desperately need that with 50 to 70 children in emergency departments every day. We need teams who can go and provide support to families in community and stick with them for a couple weeks. All right. I think the last somewhere to go, it's a bit of a somewhere to go and somewhere to respond, is NC START. A lot of you might know about START and some of you may not. So NC START is very specific. It's for people 6 and older who have intellectual and developmental disabilities and often other complex mental health needs, right? We all have mental health issues. Some people have IDD as well, right? So NC START is a really lovely team-based model, just like some of the other ones that we talked about, right? So the individual and their family and support system gets a lot of services that wrap around support to help understand the crisis, the precipitating events, learn skills to manage the crisis. NC START also has respite beds, so people can go to respite. They're not really a first responder, but if a family is involved with their services currently, they can go and respond if the individual is in crisis. Wait lists are very long. Look at the next slide. We have 3 regions. So can you imagine chunking our state up into 3 regions? It's not a lot of, it's a lot per team, right? We only have 12 respite beds statewide. So how can we better utilize NC START, better fund and better support it? Because it is a very specialized resource for individuals with IDD. The mission is the same, right? How do we help the person? How do we help their wraparound supports and family or whoever learn how to help stop precipitating events of the crisis and then to manage the crisis in community, right? That's our overall goal, right? So START is very much like mobile crisis or mobile crisis force, but it is a longer follow along service, which is really nice. All right, next slide. So that was all our someone to call 988, someone to respond, mobile crisis MORES, and some limited instance in NC START team, and then a safe place to go. Facility-based crisis, behavioral health urgent cares, NC START. So that's the model that we need. We know we don't necessarily have enough of those things across the state, nor are they well known. We want to make sure the procedures around them and the quality of services you get in those places are solid. Okay. I'm getting to the end of my slides, which is good because I want to leave time for conversation and discussion. So a lot of what we talked about was the service array, right? And some data showing the service array and kind of our vision for what we get. Let's talk about the data for a minute. We have something, it's very long. If you could go back one slide, it's called BHSCAN. And SCAN stands for Statewide Central Availability Navigator. Hence, we call it BHSCAN. A lot of people just call it the bed registry, right? So right now, we do have a bed registry, and we'll be publishing it soon, where we show the number of licensed psychiatric and facility-based crisis beds we have, the number that are actually operational. So just because they're licensed doesn't mean they're staffed in an operation. And then the number that are full on any given day and the number that are open on any given day. So it shows us and it shows the community where we have beds available, which aren't many, you guys. And eventually it will have the capability to do digital referrals in the system. So that's what we have currently. We launched it in, I think, January of 2023. So we're getting up on a year. But here's our future vision. So besides just having facility-based crisis beds and psychiatric inpatient beds, we need to get all the inpatient beds in there. We have a lot, but not all. We need to get all the facility-based crisis beds in there. We don't have them all. We need to get all the behavioral health urgent cares. We need to get the PRTF beds. So those are psychiatric residential treatment facilities. And we need to get other levels of residential care in the system. So we can understand where we have beds and where we have needs. But besides that, we would like this bed registry to be connected to 988. Remember what 988 can do? As people calling in crisis or people that just need services, and it deploys mobile crisis. So how do we make sure that those systems are connected? So 988 can get a call. They can deploy mobile crisis. That's in the system. We can track the response of mobile crisis and we can track what happened to the person later, or that system can be used by 988 or mobile crisis to help the person find a bed, to go to the right facility-based crisis, to go to the right BHUC, right? Wouldn't that be nice? Instead of the default, so that mobile crisis team knows, oh yes, my facility-based crisis actually has a bed. I could call and check, and then I could take them there. So pretty cool. So we think there's good opportunity for linking these systems together. But we want to go further than that, right? We want to make sure that our 988 system is able just to track, with their permission, additional data to help people follow up and navigate in the system. Remember all those people who are calling in crisis, but all those people who are not calling in crisis that just need a next day appointment. So how can we use the system to help get them to a next day open access clinic? We need more of those too. And track that they actually made it, right? Did they actually get a next day appointment? They called 988 because they didn't know where else to go. How do we track that how do we make a referral to a next day appointment and find out that they actually want it, for example? So we think with these dollars that we have, we won't just track hospital beds or crisis beds. More people will be able to use them, like mobile crisis teams, like 988 dispatchers, and we'll be able to track where folks are getting referred and if they're making it to those community-based services. I think I have one more topic, and Charles coming on screen, just so you know. Charles coming on screen means it's time to start answering questions. So the last thing I will talk about, I think it's my last thing, Charles. I hope, Charles, it's my last thing. Can you give me a head shake? Is the money we got for a non-law enforcement alternative transportation pilot. Now, you may know this. Probably most of the folks on the call today know this very well. Oftentimes, when people have to get transported to an emergency room or from an emergency room to a different hospital, right? You found a bed, but it's 4 counties away. They have to get transported by law enforcement, sometimes through involuntary commitment, sometimes not. And so people get transported in the back of a police car, often in handcuffs. And that's not because law enforcement is trying to be difficult. These are just protocols. So some hospitals, because it's really cool, and some communities and some other states are piloting alternative ways to transport people. So they're not transported like criminals in a vehicle in handcuffs. So people are transported again in a trauma-informed way, right? It's traumatic. This is traumatic experience you've just gone through. Being transported in a police car is quite traumatic. With handcuffs is traumatic. So like, think about a system that is not traumatizing, that gets people where they need to be in a safe therapeutic way, gets them the treatment that they need. So we got money to pilot an alternative to law enforcement transportation. So that's the final piece of our funding. So remember, we got funding for someone to call, someone to respond, in a safe place to go. We got money for the technology that hopefully knits them together and makes us smarter. And then some money to work on a transportation pilot so people can get transported in a not traumatic way. So remember, one final thing I'll say before we get to questions and answers is, remember, this is a dense thing, but our goal is to share with you all of our information. It's very high level. We shared a bunch of announcements, and we shared, here's high level how we're thinking about the crisis system and what we're going to unpack in our advisory groups to figure out how to spend the money. So please know, again, we will be unpacking all of this in much greater granular detail in our advisory committee meetings, and we'll give updates to this side-by-side group. And this, I'm going to turn things over to Charles, because I think we got lots of questions and answers. And are other folks going to turn their cameras on too, Charles, for some Q&A?
I'd encourage some of our clinical leadership who are here with us today to turn their cameras on and join. Kelly, thank you so much for the presentation. To kick us off, I'm going to ask a few questions about sort of how 988 ties into the crisis system. So can you explain the process of how 988 contacts the local mobile crisis providers? And what do we know about how EMS interacts with our crisis system? So how 988 contacts local mobile crisis providers, and how does EMS fit into this?
Do we have Sarah or Lisa? Do you want to start that one off?
Hi, this is Lisa DeShantis. I'd be happy to start off the 988 conversation with mobile crisis. When someone contacts 988 and there is the need for, or the want for mobile crisis to get involved, either the 988 counselor, crisis counselor, has two options. They can contact the mobile crisis provider for that area. They have a list of the providers, and they can do a warm transfer, do a joint conversation as to what's going on, and help get mobile crisis out there, or they can give the mobile crisis information and LME information for that area if that person decides that they want to make that call independent. So that's one of two ways that they can those are two ways of which they can get in touch with mobile crisis.
And so you know that Lisa leads our crisis services here. She's our crisis team lead at DMHDDSUS. Did I cut somebody out? Sarah. Sarah, were you saying something?
I was not.
Oh, maybe someone else was. All right. Nope. Okay.
Well, I can jump in with another question, Kelly. What is the percentage of 988 calls that result in mobilization of EMS and or law enforcement?
Elliot, do we have that on our dashboard? Or do you know it? Or
Yes,
Lisa?
yes, I can answer that. I can jump in.
Thank you,
So
Lisa.
less than 1% of calls that come into calls, chats, and texts that come into our 988 call center result in an immediate response needed from law enforcement and or EMS. That includes you know, if someone needs that immediate response, then they will only, that's when they'll call that 911 or get in touch with the law enforcement in that area.
And I assume, Lisa, there's a triage, like there's an imminent risk or issue where they call.
Absolutely. There has to be imminent risk and for them to make that judgment.
One of the things we've heard, if you don't mind me adding, Lisa, and I thank you for your expertise, is, you know, we hear people, and I want to just reinforce this message because we just shared a bunch of data. 988 is anonymous, just so you know. But after the crisis is handled or issue, we give referrals. We will ask people if they're interested in sharing some of that demographic data that we have. So it is anonymous, and people, I know people are very worried. Like, if I call 988, does everyone know my business? Are you going to ask my name? Are you going to call the police on me? So there's a lot of fear. So I just want to reassure people it is an anonymous line. There are protocols for when people do deploy. It is only imminent risk that 911 is deployed. It is a confidential line. So I'd want people to understand that. We don't even have data on lots of people because they chose to remain completely anonymous and not even, you know, give their gender or ethnicity. And that's cool too, or age. That's all cool.
We have a few questions about training for folks who respond to crisis, and training that's specific to IDD populations, TBI populations, individuals with autism. So maybe just speaking a bit more about how we envision the crisis system being able to respond to specialized needs.
So I will say, and then I'll ask the team to jump in, I will say that we have gotten a lot of, I mentioned it, I mean, that's why I mentioned it, a lot of feedback from our community of folks with IDD or loved ones with IDD or a traumatic brain injury about that very question. And one of the things that Lisa and her team are working on at the state level, but also at the national level, but the state level is most important to us, is how are we making sure that our crisis response system is trained. And we're starting with 988, right? So we're starting with our vendor to make sure that they are trained and they understand the unique needs and what trauma is like for an individual with IDD or TBI, and the way to help communicate effectively and in a culturally humble way with families or loved ones when they do respond. I don't know if you want to say more about that. And I think that idea of having 988 be a good responder is critical, but that also means making sure that a mobile crisis team that goes out is well informed too. A crisis receiving center like a BHUC or a facility-based crisis is also well equipped. I think one of the things that we know, we didn't share data, is a lot of individuals ending up in emergency rooms and staying there for a long time, or individuals that not only have a mental health crisis, but also have an intellectual or developmental disability or autism, because our system isn't always well equipped. But Lisa, please, Sarah, Petra, feel free to add to that.
I think that you covered it very thoroughly.
I'm going to jump in then so that we can get to some more questions, make the most of our time. And this is a similar kind of question to the one that we were just discussing. So is there a plan to build trust in the community so that we do use 988 more? And this question came in from someone who wanted to draw attention to the fact that revealing a mental health crisis is very, very personal. So drawing attention to the significance of trust in this system.
Yes, yes, and yes. And I think this is one of the places where we would value input from you all around what would it help? What does that look like? How do you begin to trust? What is that? I mean, that could look like a lot of things, like what would make you trust the system a lot more? If there were certain outcomes you saw or datas, or you got to see the facilities yourself. I think we want to do it, but I think we need to understand better what are the kind of things that build that trust in the system. But that's critical. Charles and I talk about this all the time. So one of the things that we are working on with our CFAC, and we want to work on with you in the public, or we're calling it an anti-stigma campaign and an accessibility campaign, because we feel really strongly about the fact that we need to all just be really comfortable about talking about mental health. The world needs to be more comfortable talking about mental health without fear, without shame. We all have mental health issues, and I proudly say I'm a person with lived experience. And so I need folks to be able to call 988, and also we all need to have that shared value and make commitments and changes in our system so people do trust that when they call, it's going to be safe. If they would like to keep it private, it's going to be private. When they go to a facility, it's a clean, safe place where they get treated with dignity and respect. And some people do have that experience, and I'm grateful for it, right? But it is a hard thing still in our society. So we want to do everything from change this whole stigma place we live in, but making sure that our systems are delivering, right? People are having really good experiences. And I think that's why we need to hear from you. Like, what would make it a good experience? What would make you trust it? And we want to do all of those things, but others are free to chime in there.
I'm going to jump in because I think what you were just saying dovetails very nicely with what will have to be our final question. And it comes from someone who's sharing that they're excited about the work that's happening here. And the question is, how would you like to see community members and providers more embedded in supporting the work of DHHS? How can we help?
Please come to our community groups. If you are a consumer or family, get involved in your local CFAC, come to the state CFAC, come to any one of our provider meetings. And we showed you the 4 meetings we have. We have other meetings too, y'all. And so if there are a group of folks that we're not meeting with or representing well, let us know. But please get involved in the ones that we advertise. You can, I think people put in the chat the ways that you can contact us, but we're super excited. Our webinars are called Side by Side for a reason. It's not just a catchphrase. This is our system. We are building it together. We all use it together. We all experience it. And we are super excited about partnering with you all and getting your feedback and building the best system. So please join any of our work groups. We're very happy, excited, and humbled to have you.
Thank you so much, Kelly. I believe we need to pass the ball to Dina, who is going to close us out.
Thank you, Charles. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our community engagement and training webpage. The links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, December 4th from 2 to 3. We hope to see you then. This concludes our webinar for today. Thank you for attending.